Good morning, everybody, and welcome to our session on improving quality of care. What is quality? Everybody wants it. We want more of it, actually. But when we really need to nail it down and say, this is exactly, what are the dimensions of quality? There the complexities also actually start. And not also with the definition of quality, but also where do we find quality? Do we find it at health systems level, organizational level? Is it something which is assigned to healthcare professionals or to process or to all of this? And if that is the case, how it is actually interlinked? And how does it relate to health technology assessment, to evidence-based medicine, and to all the other movements? And in the end, what does it mean to me as a healthcare manager? How can I use quality? What do I need to think about it? These questions we are here today to address and hopefully to resolve. And we've set up a wonderful panel of presenters with really very useful presentations. And I will introduce the presenters in a second. But before I do this, I would like to hold up the book on which this session is based. It's a collaboration between the Observatory and the OECD, and it's called Improving Healthcare Quality in Europe. And what is so special about the book, it's very concrete and very detailed, and it's very much oriented actually to the practical level from my point of view. It is for practitioners, very useful. I just opened and I see clinical practice guidelines, audit and feedback, patient safety cultures, clinical pathways. I think these are all the things we want to know when we talk about quality in a very concrete way. And today we picked out a couple of elements of this book, to illustrate and to get forward. And we will start with an overview presentation from Dimi Pantelli. Dimi is with the Observatory, but until recently she was actually working in Berlin with Technical University Berlin. And Dimi will introduce the book and the main concepts behind quality of care and the five-lens framework. I think that is very important because it brings together some of the complexities into one very good model. This will be followed by a presentation from Mirella Kakachev. And Mirella will talk about the concept of public reporting. So the question here is actually, how do we get quality into the system? And one way to do it is to talk about it, to inform the public, to get feedback to them, to make them understand how good is the quality of a certain healthcare center, a hospital, a health system. And this will be followed by another idea how to get quality into the system. We will talk about pay for quality, and Willem Quentin from Technical University Berlin will introduce the concept of pay for quality and present the evidence on current use, effectiveness, cost effectiveness, and implementation. And finally, Reinhard Busse, professor from Technical University Berlin and research director of the European Observatory on Health Systems and Policies, will give us a concluding presentation and will bring together the various strengths of it, and also I think make some reference to other aspects in the book which we cannot present here. The book has 15 chapters and is very readable, very useful. We encourage you all to come up with questions, comments, ideas. Please use the question answers. We will have, after every presentation, a very short moment for addressing direct questions. And then after all the presentations, we have reserved more than 20 minutes, for discussion. So that's about it. My name is Matthias Wismar from the European Observatory. I'm the facilitator today, and I will take you to the program. And I give the floor to my colleague, Dimi.
Thank you, Matthias. And trying for proper social distancing here, we lose you from the screen for a second. Thank you for having us. So starting from the beginning, I'm very grateful to be here today with Matthias, but also with my colleagues from Berlin University of Technology, Technische Universität Berlin. Reinhard, Willem, and myself worked on the book that Matthias mentioned together with Nick Klassinger and a great group of authors, a big group of authors, specialists in their respective areas. So what I'm going to try to do in the next 10 minutes is to give you a little bit of an introduction into why we did the study, what the study uses as a conceptual framework and a definition for quality, and what you can expect to find in the book. And then colleagues, as Matthias said, will introduce individual strategies, and Reinhard will conclude with how this works. So you saw the book already, we can move through that. was important to understand for the background of the study, and all of you who are here today are interested in the concept of quality and how we measure it and how we can assure and improve it, is that it is a very commonly cited principle of health systems and health policy, and a priority. But very often we talk about quality and we understand different things when we talk about it. That's because there are a number of definitions out there that over the years, starting with the work of Donabedian in the 60s, have evolved in a different way, and they are confusing in the sense that beyond effectiveness, safety, and responsiveness, we'll come to that in a minute, that are core dimensions and that are by now recognized, there are other elements that are sometimes mentioned, such as access, appropriateness, efficiency, and equity as attributes of quality. And that makes it difficult to pinpoint what it is and correspondingly how to measure it and what to do about it. On top of that, if we take the policymaker perspective and the manager perspective, there are a number of different movements, such as evidence-based medicine, health technology assessment, accreditation, different types of things that you can do to assure and improve quality. And often, for policymakers and for managers, it's very difficult to prioritize and very difficult to understand what all can help and cannot help quality. So the point of the book was to provide a clear understanding of what we can define as quality, what different types of concepts we can use to measure, assure, and improve it, and how they link together, and how policymakers and managers can prioritize and align strategies to ensure that overall, in the end, the aggregate, the quality in the system is improved. So this was the goal behind the book. Having a little bit of trouble. As I mentioned, we have a number of definitions. We won't go through them in detail. The important thing to note is that over the years, there has been an evolution in what quality means and what understanding is behind it. We started with the ideas that there is a desirable outcome that we are trying to reach using legitimate means in Donabedian's definitions, and we try to minimize undesirable effects of healthcare service delivery. If we look at it from the system perspective, it's a different topic. We'll come back to that in a minute. Over the years, with different perspectives, we see that we need to understand what we can do in healthcare using legitimate means to increase or maximize patient welfare, and that includes what patients themselves find important. So over the years, we crystallize these dimensions of effectiveness, safety, and responsiveness to highlight quality of care. And as we show here, and I mentioned previously, in different approaches, also other dimensions have been mentioned. The book does a very comprehensive overview of the different dimensions that have been used before. So Matthias, can you perhaps, thank you. We won't go into a lot of detail here, just to say, for the purpose of the book, and we come back to that when we talk about the framework, we talk about effective, safe, and responsive healthcare services as those that are of high quality. Our book came at a time where, I think we need to go one back.
Sorry.
No problem. At a time where there was a lot of initiative going on about quality, different organizations shed light on different aspects, such as national policies and strategies, different ways of measuring. Patient safety was a focus, delivering quality of care, but we didn't find a comprehensive overview of specific strategies and how and what we know in terms of evidence on how they work, if they work, and how we can implement them. That's what the book tries to do. Provide a comprehensive framework for understanding, measuring, and improving the quality of health through a variety of strategies, giving an overview of activities in Europe, so what we can learn from practice, and an overview of existing evidence from empirical studies on effectiveness, where possible cost effectiveness, and what we can do to implement these strategies, especially aimed at policymakers. So we look at the macro level, but of course, as you know, the managerial efforts in that area are not far removed. We try to bring together, and this is another contribution of the book, different notions that have been used and different frameworks that have been used in the past to show how we can measure and how we can operationalize quality. Because if you focus on individual ones, maybe you are confused about what the other ones do. So we try to bring all of those together, starting with the triad that everybody knows. That's one of the elements that everyone agrees with when it comes to quality, measurement, assurance, improvement. Donabedian's seminal work that looks at structures, processes, and outcomes to understand at which levels we can measure quality and which levels can we aim to improve it. The structure, meaning the setting in which care is provided, processes, everything that is entailed in the process of delivery of care. And then, of course, outcomes, be it hard outcomes like mortality or morbidity, or intermediate outcomes, which we also call surrogate outcomes, like blood pressure, for instance, or blood glucose levels. We also look at the 3 dimensions that I mentioned. This is a different framework. The Healthcare Quality Indicator project created this framework for the OECD and looks not just at the 3 dimensions, but also different areas of care. And the notion is that patients or people use or seek care for different reasons. And we can look at quality at all these different areas of care, and it might be different because we need to use different indicators. One example that we give in the book is that mortality, for instance, may be a good indicator to look at acute care, hospital care, but for obvious reasons, it's not a good indicator for palliative care. So we have different areas of care: primary prevention, chronic care, acute care, and palliative care in the book. And one important notion here, looking from this slide to the next, is how this cluster within the Healthcare Quality Indicator project fits within the general notion of health system performance. Because this is one other area of confusion, the differentiation between quality and performance. Because in many situations they are used to mean the same thing, which means the quality of the healthcare system as a whole. The extent to which it actually achieves its intended goals. So what we try to do in the book is to say, in order to zero in on how we can improve healthcare quality, we zero in at the healthcare service level and say this is quality of care. If we look at the health system level and the extent to which it can achieve its stated goals of improved health, responsiveness, financial protection, and efficiency, we are talking about the overall health system performance. So we make a difference here between the quality of healthcare service delivery and the quality of the health system, which is, in that sense, performance of the health system. So we use the term quality specifically only for the healthcare service delivery area. And the framework for that we propose in the book is that quality times access and accessibility. That means that the first dimension includes both coverage and realized access, are important, or are together lead to improved population health outcomes and improved responsiveness. And if we put them in relation to all the inputs we need in the system, be it financial or other types of resources, we come up with a dimension of efficiency, and all of this together is the notion of performance of the health system, and it clearly differentiates between the notion we use for quality in the book and the notion of performance. So if we combine all these different strategies together, all these different approaches together, we have different dimensions that we can look at. The Nabedian triad, but also the 3 dimensions of quality and the areas of care. We also need to think about this idea that quality improvement is actually a cyclical activity, and that we need to be thinking about setting standards, monitoring the standards, and assuring improvement. So we add another dimension that is based on the PDCA cycle that all of you are aware of, and this cyclical idea of affecting change in health systems, also known from other systems like the Girard trilogy. And we also argue that you have to differentiate between the targets. Thank you. Between the targets of healthcare quality improvement strategies, and I cannot move my slides anymore.
That's terrible.
We have that far. We have 4 dimensions. I start from the beginning, and while we look at it in a way, there we go. That far we had different dimensions, and I will take a deep breath and say that again from the beginning to the end. And this is my final slide. I won't show the rest of the slides so that the other speakers can have a little bit of time as well. We start with this notion of the universally agreed dimensions of healthcare quality, of effectiveness, safety, and responsiveness. And we're moving here from the center outwards to understand this framework that the book puts together. On top of these 3 dimensions, we use the areas of care to differentiate between the different focus of different quality improvement strategies that we analyze in the book. We also look at the activities of quality, whether we're talking about setting standards or monitoring improvements or assuring improvements. And we also, of course, put that in conjunction with the Donabedian triad of structures, processes, and outcomes. And finally, in terms of understanding where a healthcare quality strategy or improvement initiative, as others might say, where it needs to be placed within healthcare system action, we look at the target and we differentiate between payers, provider organizations, professionals, technologies, and patients. So we use this five-lens framework, looks like an onion if you cut it, to try and describe different healthcare quality strategies. And so in order to understand them, measure, and in the end, arrive at quality improvement. I think now I can move the slides. I think I wrap up here with saying this is the framework that underpins the entire book. For each strategy in the book, we ask questions about effectiveness, cost effectiveness, current activities in Europe, and implementation. And Reinhard will pick up from this spot at the end of the session to bring all of the different insights together. Matthias, back to you.
Thank you. Thank you so much, Demi, for this very quick run through, which is actually the history of almost 60 years of quality discussion. I just looked it up. Donabedian's first publication on the evaluating the quality of care is from 1966. And I think quite nicely you put this into a framework to make the differences between healthcare, health systems performance assessment, and various lenses. And also, I think it is almost, when I think about governance, we have the same issue that we agree on a couple of core dimensions, but around this, there's not so much agreement. So we have a couple of moments time for clarification, but I see at the moment there's nothing in the chat. If you have questions later on for Demi, please feel free and still put it into the question and answers, and we will pick them up later on. Otherwise, I would suggest I just give the floor to our second speaker, Mirella Cacace from Catholic University Freiburg. Please, Mirella, the floor is all yours.
Thank you. Thank you, Matthias. So thank you very much for inviting me to this session to report on the quality in healthcare systems in Europe. I will present on a topic I worked on together with Max Geratz and Elke Berger. It is public reporting in healthcare systems, and I will show you some the content of what has become the chapter number 13 in this wonderful book. And yeah, thanks again for inviting me for this presentation. In my presentation, I will start by defining public reporting and show what the mechanisms are like that I used in this instrument of quality improvement, hopefully improvement. And I will show some international approaches. I will present something on the evidence, on the effectiveness of this instrument, of this quality instrument, and give some recommendations we learned from international healthcare systems for their implementation. And I will conclude, of course. And I hope I will be as speedy as Demi was. So I start by defining public reporting. For public reporting to be used as a quality strategy, it is important to know that we need that the format is that information, quality-related information, is reported to the general public, meaning that the information addresses really the broad public and is understandable for lay persons to be informed about quality. Second important point of the definition is that we need to have information on non-anonymous providers. So providers need to be identifiable. And these data needs to be collected systematically. So we need somehow a comparative approach to this data collection on quality. Public reporting is addressing the general public, which means that it is not an unsystematic feedback and single open comments by healthcare insurers or in the mass media, but it needs to be systematic in order to promote transparency and informed choice of provider, to stimulate quality improvement, and finally also to hold providers accountable for the care they deliver. So this is the major aims of the strategy. We have two general pathways through which public reporting can potentially become effective. The first pathway is called the so-called selection pathway. Here, through this pathway, the idea is that the information provided enables the user to make an informed choice. So this public reporting information is an instrument of patient empowerment. Consumers shall vote with their feet in the sense that they select good performers and discard bad ones. So in the terminology of Albert Hirschman, this is exit options, voting with their feet, changing providers. But of course, there is another pathway which is called the change pathway. And this pathway is working through the providers themselves. The providers, through this performance information, can compare themselves with their peers. They can identify a so-called level of expected quality and identify an area of underperformance potentially. And this can be a stimulus for quality improvement. In Hirschman's concept, this would be rather the pathway that works through voice, which makes the providers change their behavior. Meanwhile, many international healthcare systems are using this approach. They are investing in public reporting. I have only some examples here, but there are many, many more. And of course, all these systems use the concept Timmy introduced already, obedience, trias of structure, process, and outcome indicators. I brought an example from the NHS England. This is most suited because everybody would understand these indicators, because it's in English, of course. And here you see that the indicators are presented. There are several levels, several layers to present the indicators. I choose here the key facts only, and again here this system is very rich of indicators. What you see here are some results the Care Quality Commission Care Quality Commission inspection. We see some recommendation indicators, and we see a very important indicator also, which is the mortality rate. And at least a good public reporting system also explain what they do. And this is also the case with the NHS England examples. Here, if you click on the information symbol, you would see that the mortality indicator, for example, relates to the 30 days, the mortality within 30 days of discharge, and you would find how this indicator is constructed and what the user needs to know in order to interpret it correctly. So the user is also requested to invest some time to try to understand what is going on here. And yeah, as you see here, there are also options to make it easier for the user to understand by providing intuitive symbols like this green symbol or the red symbol, making the user aware of differences in quality. What is important is the comparative approach as well. You see it easily here, that you can add the hospitals, for example, to a short list and make a direct comparison on quality indicators. So overall, what we see in Europe, that public reporting is increasingly used. It's covering more and more sectors, including the long-term care sector, for example. We see that public government or governmental sponsorship is very common. But of course, as I will explain later in more detail, there's a difference between hospital care and physician providers. The data that is used, if the government is monitoring the system, is frequently quite complete and systematically collected as well. And it's increasingly collected via surveys. So very systematically. A major aim of the public reporting strategy is to have full coverage of the providers in order to get complete data. We have increased, for that reason, we also have increasingly mandatory public reporting in specific sectors. For example, Netherlands or also Germany is a good example, with the obligation of hospitals to provide a quality report, a structured quality report on the data. Frequently, and we will hear more certainly later by Willem, public reporting is quite frequently also linked to pay for performance. To pay for performance models. So, and as already said, there's a difference between hospitals and physician practices. Hospitals, quite frequently, there is a public mandate, and these systems are improving. Initially, we had a focus on quite simple, I say, process and structure indicators, and increasingly real health outcomes are presented in public reporting systems. This is not the case so far in physician practices. Here we have only one example from England, that the quality and outcomes framework-based system that is providing kind of outcome indicators, or rather intermediate outcome indicators. But we in the physician practice area, we have quite frequently only I say, which is we have less clinical indicators, and we have more the patient satisfaction as an important outcome indicator. And interestingly, in the physician practices side, the more bottom-up approaches, the physician rating sites, are rapidly expanding. What do we know about the effectiveness of these public reporting systems? Well, first, it is difficult to insulate the effects of public reporting on quality because public reporting comes with many other measures of quality. But we have a clear hint that the quality is improving. The health outcomes are improving through public reporting. Most importantly, here is a meta-analysis conducted by Campanella and colleagues in 2016. But what we also know already from a very early example, the New York State cardiac surgery reporting system that has been developed in the 80s and 90s in New York, we learned that information is very easy accessible. It was then in the newspaper, of course, there was no internet yet. And the information was presented on a very low complexity level, but still people were not using this information. And so we have this indicates already that the selection pathway might not work particularly well. The selection pathway where the provider shall vote with the user shall vote with their feet and switch to high quality providers. And this is quite puzzling, and it is revealing to look at this consumer choice model, at the consumer choice models that distinguish between for major step. Oh, sorry, something's wrong here.
Mirella?
Is it okay with the slides?
Yes,
yeah.
Okay, but
okay.
Just 1 more minute. We're running out of time.
How much time do I have?
1 more minute.
Oh, so I think I will essentially need to skip this model in detail, just to know that for the audience it is important that this selection pathway is not working too well. What is more important is the so-called change pathway, where the providers themselves, they adjust themselves to the quality information, and they are most responsible to the data. However, we see some potential pitfalls as well. We find that the evidence shows that there's incentive for risk selection through the public reporting. There's some evidence that there's poor performance in areas where quality of care is not measured, or other ambiguities in reporting data, to outright fabrication. So I come to the conclusion, which is that there is an increasing use of public reporting in many European countries. The selection pathway seems not to work too well, but publication of quality information is of importance too for the provider change. Evidence suggests that public reporting has positive effects on on the process of care and on patient outcomes, but there is certainly a need to improve data and also data access. Yeah, most data is presented on the internet, and we still know that the elderly and also the less privileged in terms of education do not use the internet as as a media to inform themselves on health information. So we need to, of course, we need to strengthen literacy, data literacy, in order to provide an equal access to that data, yeah, because these population groups are also in the most need of care, and so we don't want to have a group that needs that receives a second. Sorry,
Mirella, you must come to the end.
Yeah, I am. So we want to have an equal access and easy accessible information. Thank you very much.
Thank you so much, Mirella. I think it was a very clear presentation, and it's also very clear that we should focus not on the selection pathway, but on the other pathway, even though it has quite a number of limitations, and it's quite tricky actually to implement if I read this. And therefore, it's probably one of the elements, you know, to assess quality, and not the only one. And probably you need to use it in a kind of triangulation, that you pair it with other information on quality. At the moment, we have no question in the chat box, and because we are running a little bit behind, I would like to go to our next presentation. It's from Will Quentin with colleagues, Helen Eckert, Peter Smith, Pay for Quality. And this is another way how we get quality, more quality into the system. Please, Will, the floor is all yours.
Yes, thank you very much. I will present on Pay for Quality, using financial incentives to improve quality of care. This is in fact the title of the chapter also in the book, and I think it follows nicely after the presentation by Mirella, because Pay for Quality and public reporting are often interlinked, and often countries in fact start by introducing a public reporting system before they then try to provide direct financial incentives and also pay for quality of care. The chapter and my presentation follows the same structure as all other like strategy chapters in the book. That is, first I will introduce the concept of pay for quality and define its characteristics and the underlying rationale. Then I will go into provide an overview of international pay for quality programs before I turn to the effectiveness of pay for quality as a strategy to improve the quality of care. And I have one slide also about implementation considerations during implementation of pay for quality programs. To start, defining pay for quality, there are two defining characteristics. First, pay for quality uses and monitors the performance of providers in relation to pre-specified quality indicators. And second, a monetary transfer is made conditional on the achievement of or improvement of measured quality of care. So it is important to first measure the quality of care and then to pay in relation to the quality of care that is being provided. And in fact, pay for quality, I prefer this term. I say pay for quality because it is a more specific term than pay for performance, because many pay for performance programs include some aspects of quality, or they measure certain aspects of quality of care, but other pay for performance programs in fact don't measure quality of care, and therefore they are not pay for quality programs, but they are pay for some kind of performance programs, and they may target many other dimensions of performance. So if we think about pay for quality as a quality strategy, it's important to know only those programs that actually measure the quality of care, as this can help to improve the quality of care. And the underlying rationale of pay for quality is that traditional payment systems do not provide direct incentives for high quality of care. Neither fee-for-service nor capitation. Fee-for-service may lead to over-provision and therefore low quality of care, whereas capitation may lead to under-provision and therefore low quality of care. Neither is directly related to the quality of care that is being provided by providers. The assumption is then that providers will improve quality if they have a direct financial interest to do so. That is the underlying rationale. And the proponents of pay for quality programs, and pay for quality is a relatively controversial strategy, and because it is related to direct financial incentives, and the proponents of pay for quality say that the intrinsic motivation and the non-financial incentives are not enough to motivate improvement of quality, whereas opponents of pay for quality programs say that the financial incentives may in fact crowd out the intrinsic motivation of providers and lead to adverse consequences like an exclusive focus on the measured indicators and ignoring other important aspects of quality of care that are important, or other aspects of care that are important in order to improve the quality, but that are not directly measured or more difficult to measure, and therefore not included in pay for quality programs. Now, I use this framework that has been introduced by Dimi in the first presentation to discuss the characteristics of pay for quality. And this slide, you have seen it in fact already. In theory, pay for quality can focus on preventive, acute, chronic, or palliative care. It may aim at improving effectiveness, safety, and/or responsiveness, depending on what indicators and what types of indicators are measured that are indicators of effectiveness, safety, and/or responsiveness. And also depending on the indicators that are used to measure quality of care, it may focus on structure, processes, or outcome indicators. And in theory, it may target both professionals and organizations. And however, in practice, pay for quality usually focuses more on certain areas of care, and certain characteristics differ across areas. And that I will show in the next slides that give you an overview of pay for quality programs in different European countries. So when looking at pay for quality in primary care in Europe, we see that in fact there are 14 programs in 13 countries, and that is because there are 2 programs in France. But there are programs in many European countries, although these are in fact rarely discussed in the literature. In the literature, you will mostly find information on the pay for quality program in the UK. And most of these programs, so I show you first the total table, but because it's easier to see the information directly, I'm highlighting certain elements that most programs are implemented at national level, but there are some regional programs in certain countries, and about half of these programs are mandatory and the other half is voluntary. The P4Q programs were introduced starting, the first we found was a program in Germany introduced in 2001 related to a disease management program. And the last we found was in 2016 introduced in Poland. And almost all programs focus on prevention and chronic care, and they focus less on acute care and palliative care. And most programs focus on the effectiveness, for example, the compliance with guidelines, and only 4 programs include indicators for responsiveness. Concerning the types and numbers of indicators, most programs focus on structures and processes, but there are also 6 countries that reward outcome quality. And most programs focus on providing bonuses, or they award bonuses to providers and these are almost always based on absolute performance and not on relative performance. So there's the difference whether performance is measured in relation to the performance of other providers, or whether it is based on the absolute performance of achieving certain points in on a quality indicator. The size of the financial incentive varies between very little, like 0.1% to 15% or even 30% in Portugal. And usually it's the individual or the organization, about half-half, that receive this bonus in pay for quality in primary care. In hospital care, there we found 13 programs in 9 European countries, and that is because there are 5 programs alone in the UK, in England. And they were introduced starting in 1998 and then up to 2015, the last program that we found introduced in Croatia. And there are some differences. I don't want to go through all the elements here again because we don't have that much time, but again, there are about half of the programs are mandatory, the other half is voluntary. There are more programs that also include aspects of safety in their indicators and therefore reward the safety aspects of quality. There are more programs that focus on outcomes and fewer programs that focus on structures than in primary care. And there are more programs that have penalties or withhold, so that don't provide the full amount of reimbursement if the quality of care is too low. And again, the proportion of total reimbursement that is related to pay for quality is usually between 0.5 and 10%, so it's a rather small amount of the total hospital budget. To look at the effectiveness of pay for quality, we conducted a systematic review of reviews, and we identified 34 reviews covering 15 countries. And most reviews, in fact 18 reviews, included studies only from the United States or England, and there were only 16 reviews that included also studies from other countries. And in fact, even those were often focused on English-speaking countries like Canada, Australia, or New Zealand. And we found many more reviews on primary care, 18 reviews, and only 4 reviews specifically on hospital care, and 12 reviews that were not limited to specific providers. And using again the framework to understand the results of the systematic review of reviews, we first look at the effectiveness of pay for quality in primary care, and on studies that evaluated the effectiveness in chronic care and in preventive care. There were most studies, in fact, focused on the effectiveness of chronic care. The reviews included a total of 124 studies. And looking at the processes of care, these reported mostly large positive effects in observational or uncontrolled quasi-experimental studies, but no effects or small positive effects in better designed studies, so in randomized controlled trials or interrupted time series studies or other studies with a control group. Concerning health outcomes in chronic and preventive care, in primary care, there were more mixed effects on diabetes-related hospitalizations and long-term complications and emergency department visits. There were no effects in chronic care on all-cause mortality or 30-day mortality or readmissions and ED visits related to acute myocardial infarction. And there were no effects in primary care, in preventive care, on quit rates or smoking prevalence. In hospital care, looking at processes of care, there were 30 studies of 15 P4Q programs, and they found in studies with comparison groups, so in better designed studies, some small short-term and or non-significant effects on a composite of multiple processes of care measures, but positive effects for some individual indicators. And studies without comparison groups usually found more positive effects on breast cancer and AMI. And concerning health outcomes, there were fewer studies that in fact looked at health outcomes of care as a result of the pay for quality programs, and they found only short-term positive effects, but not in the long term. And the lower quality studies sometimes found positive effect, but the better quality studies did not. So there, in summary, there is relatively limited evidence that pay for quality is effective in primary care or in hospital care, and it's usually the less well-designed studies that find positive effects, whereas the better studies do not find positive effects of pay for quality. And during implementation, there are a few points to consider. First, one has to think about who to incentivize. Should it be the organization or the individual? What to incentivize? And there it's clear that it's best to have a comprehensive approach that covers different areas of care, so to avoid that providers focus on certain aspects of care and ignore other aspects of care. How to measure? There are many guidelines for how to measure quality of care, and there's a whole range of indicators, and there are many examples in existing P4Q programs that can be used to get inspiration about how to measure the quality of care in both primary care and hospital care. The size of the incentive is an important question, and on the one hand, it should be large enough to potentially achieve an effect. On the other hand, it should not be too large to avoid that there are unintended consequences and providers focus too strongly only on the measured areas of care and ignore other aspects of care. And there are many theories about the design of the incentive, whether it's better to use a penalty, a bonus, to reward attainment or improvement, and often it's good to have a mix of these approaches in order to provide more balanced set of incentives. And concerning how to implement a pay for quality program, an important aspect is that it should be implemented in a way that enables systematic evaluation and periodic re-evaluation, because otherwise it's unclear what the effects of the program really are. And it is surprising that although there are so many pay for quality programs in European countries, there are relatively few studies that have systematically evaluated their results. And what is important also is that during these stages and in designing the pay for quality program, all relevant stakeholders are involved, because if they understand what is expected from them, only then will the program lead to the improvement in quality of care that is desired by P4Q programs. So this brings me to the conclusion that P4Q is increasingly used in many European countries. However, there's relatively limited evidence from European P4Q programs, except from the UK, and most evidence is from the United States. And the studies report mostly positive effects, but mostly for process measures, not for outcomes, mostly short-term effects, no long-term improvements, and mostly based on low quality evidence. And that in summary means that there's relatively limited evidence that pay for quality has positive effects.
Wilm, thank you so much for this overview and the very critical appraisal actually of the evidence. And if I understand it correctly, the weaker the quality of the study, the bigger the quality improvement of the strategy. But actually, you were also pointing maybe to one of the reasons of this, and we need to look more into the implementation process, and we need to, number one, implement the pay for quality strategies more skillfully, but probably also analyze them a little bit different and look how it is implemented to have a real good understanding, you know, why it's not working. We have a couple of questions. One is quite complex, and we need to address this. I think at the very end, it's about mixed rates for diabetes-related diseases. Maybe it's number 1 and number 2 type. And then we have a second question, Will, which I like to put to you, is does pay for quality risk increasingly poorer outcomes for patients already receiving lower quality of care? So like, for example, if there are service providers already underperforming, will its failure to access financial incentives exacerbate inequality? So that is something, you know, I was wondering about the exit strategy as well. You know, if people see that my healthcare center is performing badly, they go to other places, and then accessibility in this area is declining, and the volume of care is declining, and maybe the quality is declining as well. So can it have a negative effect on the quality if there's no top-up payment for quality improvement?
Yeah, that's a good question, and I think it's one of the criticisms that is often raised in relation to pay for quality, that in fact it might lead to unintended consequences if the poor performing providers then receive less money. And one consideration is also whether it is in fact fair for providers to provide poor quality of care and then to get less money, and they can simply decide to always provide poor quality of care for less money instead of providing good quality care for more money. But that's wouldn't really be fair for patients either. So and whether an appropriate approach would not be then rather to either to close down providers that continuously provide poor quality care in order to make sure that patients would get better quality care, or to change the management of the providers and to have a more active strategy to improve the quality of care by certain providers. It
also assumes that the intrinsic motivation to do a good job is entirely lost, actually, and that's almost corruption.
And thank you. Provider.
Yes, thank you so much, Will, for this very interesting presentation and for answering the question. There's one more which we park for the time being, which we will come back. And now I would like to give the floor to Professor Reinhard Busse, who is going to tie together the different strands of these presentations. And Will, yes, the different strands of these presentations, and give us a little bit of a concluding overview. And afterwards, we have an open discussion. So please send us your questions and we will feed them back to the presenters.
This is the conclusions presentation, and I try to summarize what is in the book and provide some insights into synergies and maybe what is left open after looking at all these strategies. Dimi has already very well explained that we chose this five-lens framework, and obviously it was our task to then look at all the different strategies which are used to improve the quality of care, starting from mandatory accreditation, health technology assessment, right down to the two strategies which we just heard about, the public reporting and the pay for quality. And actually, we also had a choice of how to sort and present these strategies. In the end, we went for the quality improvement cycle idea. So with the setting standards, the steering and monitoring quality of processes, and the leveraging processes and outcomes of care, which was then our defining framework. And we looked at 12 strategies in more detail, and of these, 4 we sorted into setting standards for structures and inputs. We looked at health professionals, health technologies, healthcare facilities, and last but not least, external institutional strategies like accreditation, certification, and supervision, which already has an overlap to the next strand, which is steering and monitoring quality of processes, where we sorted clinical guidelines, audit and feedback, patient safety strategies, and clinical pathways. And last but not least, we sorted the 2 strategies which we just heard about, public reporting and financial incentives or pay for quality, into the strand leveraging processes and outcomes of care to assure improvements. As already stated by my previous speakers, all chapters follow an identical structure to enable the reader to actually compare the strategy. So we always looked at the question, what are the characteristics of the strategy? What is being done in Europe? What do we know about the strategy's cost effectiveness and first the effectiveness? How can the strategy be implemented? And last but not least, conclusions for policymakers. I'm trying to summarize these really very, very briefly, and unlike in the book, we go the opposite. So we start from the back, because this is just what we heard. And when we look at this, and I don't want to repeat what we have just heard, but I think it's already understandable from the 2 presentations and how differentiated the picture is, that it is quite difficult to condense it. So I try to condense it here even more by giving you the characteristics of the strategy and then the implementation in Europe. And what I also try to do here is I know this is oversimplifying. I try to press it in 3 categories. So green would mean well developed or good evidence. Orange is in between, and a red background would mean not very developed in Europe, or no evidence on positive effects. So what we try to do here, and you just heard that the 2 speakers said, yes, there is activity, there's growing activity. And for these 2, I would still say it's not that we see it is used in every country consistently. So this would be like an intermediate activity level, even though it's growing. And then maybe even more challenging is asking how good is the evidence on the effectiveness of these strategies. And you heard that both speakers were saying, yes, we have evidence here, but there is also There's also lack of evidence, especially from Europe. And so I think these were two good examples also to understand when I will turn to the other strategies in a second, that I rated here, or we rated in the book, that on public reporting, that you can say, yes, there is evidence for improved care processes, and that it is especially the evidence if performance starts at if the baseline performance is low. We also heard from Will just a few minutes ago that there are positive effects on the pay for quality, but it's not as developed, not as broad, and especially worrisome is the fact that the evidence is lower, or the size of the effects is lower if studies are done better. So this would be like an intermediate rating of the effectiveness here. I now go backwards. So we now look at the middle column of the framework I presented, which is on steering and monitoring quality of processes. And we have the clinical guidelines. And we see again medium activity. We have many countries with clinical guidelines. We have certain countries as leaders, other countries like in a second tier, but there are still countries where this is less developed. So this would be like an orange type of activity. We have audit and feedback, and again we see activity in many countries. In some countries it's well developed activity. In other countries, at least, it's not as developed, possibly also only not as visible. Then we have patient safety strategies, and patient safety strategies, we have marked this in green here because we know that basically all EU countries have patient safety strategies, and in 20 of the EU countries, it's even mandatory. The last one are clinical pathways, which, unlike clinical guidelines, focus on care processes within institutions, mostly hospitals. Again, we have, similar to clinical guidelines, we have some countries with very established systems and other countries where there is little or no activity. Turning to the effectiveness, we actually, and maybe most surprising is, and this is, I think, a general remark which we found. I mean, we have people here designing and implementing quality improving strategies, or strategies which should improve the quality, and they sometimes go very rigorously demand good evidence when they design, for example, clinical guidelines, but that the evidence on clinical guidelines itself is very weak and actually shows mixed results, which is rated in red here. Audit and feedback has very good studies showing a good effect, while patient safety strategies and clinical pathways, yes, there is evidence on their effectiveness, but it's really limited and only available in niches. So actually one would need better studies. I come back to that in a second. And the first strand, setting standards for structures and inputs, which deals with regulating the input in terms of professionals, in terms of health technology assessment, in terms of healthcare facilities, and last but not least, the external assessment strategies. We see that most all countries have activities relating to the professionals with entry requirements, professional development requirements, strongly influenced by EU regulations. We also have, maybe as the strategy which saw the largest increase in take-up, health technology assessment, and as you might know, it's now discussed, or there is a European network on HTA, and it's discussed to make this even more mandatory. And so we have HTA agencies in the majority of EU countries, and this is why it's marked in green. Regulating the input in terms of healthcare facilities is more mixed, and the same is with external assessment strategies, even though some of them exist in most countries. If we look, and this is a bit sobering actually, that some of the most widely used strategies, you could say the strategies which have always been used, that there's actually little or no research or evidence on its effectiveness. And that applies here. You see 3 of the 4 we rated in red here. That this is there are clearly gaps there. This leads me already to the conclusions. I mean, we have seen, by looking at all these 12 strategies in detail, many countries in Europe have implemented several of these qualities strategies, often in isolation. I can already jump ahead, with rising activity levels and visibility of individual strategies. So we see also across European countries often more coordination within one strategy, that all the HTA people, all the guidelines people, all the audit and feedback people, they come together in networks, but that the other strategies are isolated. Several of these strategies, looking again in isolation, are effective, primarily regarding process indicators. The size of these effects is generally modest. Data on relative effectiveness, meaning the relative effectiveness of one strategy versus another strategy, let alone its cost effectiveness, are often inconclusive or unavailable. And Wilm has already stressed the fact that many of these data on the effectiveness and cost effectiveness are actually not from European countries, but often from the US. And so we actually know very little whether the effectiveness in Europe is larger or maybe smaller or not existing than what we see in the literature. And so the main problem which we identified is actually that the quality strategies which are implemented in many European countries are often not coordinated or placed within a coherent policy or overall strategic framework. And going back to it, I said we sorted it by this PDCA cycle with setting standards, monitoring, and assuring improvements. But actually, it would require that you combine all these strategies and the strategies which we have not looked at. There are more strategies into a coherent framework, and we would say this is really where the attention of policymakers, but also managers inside their institutions should be on for the future. Thank you for listening to our presentations.
Thank you so much, Reinhard. That was quite fascinating. It was sobering and also very honest. And I have a couple of questions instantly, and I think we also have questions from the floor. My first one actually is, you showed the uptake in European countries, and some strategies, such as, for example, patient safety or professional regulation, the uptake is universal in Europe. All countries are doing it. Others, it's much more selective. And I would like to understand a little bit the selectiveness. Is it kind of a conceived and expressed strategy to say we do this but not that because it fits better to our context? Or is it rather what you were talking about, the networks, they have a favor or a flavor for this and that and not for the other? Is there a clear overall strategy? Because your last slide actually implies that you need to bring together the various elements. And how do countries discuss this at the moment?
Well, I think I mean, if we are, I mean, if we look at countries' policies, because there are no good or hardly good examples of overall quality strategies, because I mean, in the ideal case, you would say country X is saying, okay, we do like a review of possible quality strategies, and we look which ones would be most fitting for our context. Where do we have the largest quality gaps, and which strategies are the most useful to address these gaps? And they might say, okay, out of the 12 strategies, we favor these 5 because they would help us most. This is not the case. It's not in European countries. It's not a rational approach which ones to use or not to use, but it's rather the ones which you saw in green and which you mentioned, which are universally used, is often the result of EU and other international influence on countries to do something. And the other ones, which are selective, I would say, in their uptake, is often the result of individuals, of associations, address or bringing forward certain strategies. So you have a certain group of people who say health technology assessment is actually very important, and they bring this successfully to the policymakers to introduce it, while in other countries the clinical guidelines people are more outspoken, and so that country would start with clinical guidelines.
Yes, so I think there are 2 issues before Dimi you come, and I put this question to the 3 of you actually, and then Dimi has another question. The number one is, yesterday evening we were actually discussing the role of the EU in health and health care, and as I understand what you say, Ryan, and maybe we can discuss this, there is probably a role in funding research on quality strategies, not necessarily only individuals, but also how they link together, what makes a good mix, and how to implement them. And Willem, you could also maybe comment on this, because I'm still not entirely clear, is pay for quality so negatively evaluated because we are looking at the wrong things, implementing it badly? And if we implement it badly, then the effects are certainly very low, so that would be a question. And Mirella, also for you, also in perspective with the research, I think you were very clear that the access pathway is not viable, but the other ones seem to hold some potential. So what would be the research strategy to go forward? And then after this, I would also like you to comment, with a view to the hospital managers and the sickness fund managers, and the people from the health authorities. I think they find it all fascinating, and it's great that it's coming together. But what, with this evidence, are they going to take away from the research? Because the research is, and rightly so, very critical and differentiated. So, but what would they take out of it? Please, can we make a round? Maybe Dimi, you want to start?
I want to start. Maybe Matthias, I will weigh in on a couple of things, but before that, I would like to just build on what Reinhard was just saying, to say that on the very first page of chapter 1, we look at drawing on previous work by the WHO and the reasons why someone might be interested in quality at the national level. And that goes back to your question, why some strategies are in some countries and other strategies are in all countries. There are a number of reasons, that being, as Reinhard said, that there is a more forceful movement, or maybe external pressures. And you brought up safety as an example, or HTA as an example. If there is like an EU framework or a big collaboration initiative that is funded, then it's likely that the country will implement it. And we need to make a difference between having it on paper and actually implementing it in practice. So what we see in the safety chapter, for instance, is that many countries say, well, yes, we have this, we passed this law because we have to, but this is actually not being implemented at some level. So this, I think is important. And on the other question, you have a body of evidence that is limited for actually all the strategies in one way or another. I think that was one of the motivations for the five-lense framework, also for policymakers and for managers, that you need to understand, where is my problem, what can I do, and how does this strategy then align with other strategies in the system for a coherent strategy, as Reinhard was talking about.
Thanks, Dimi. I think that is very helpful, very clarified. Can we still do the quick round, Mirella, very quickly on where you see the research perspectives to strengthen, the public reporting bit to get a better understanding on the effectiveness, but also on how to implement this and how to avoid, for example, gaming with. We have this saying that a good indicator ceases to be a good indicator when it becomes a target. How can we avoid these things, and what can research do with it? And what would you recommend practitioners?
Well, of course, one of the most important strategies in order to reduce gaming and to make also the systems more accessible to more people is to improve risk adjustment, because it is one of the major failures because we all want to have the data that are interesting for the public as well as clinical outcomes data, but in order to make these data presentable to the public, we need to make sure that the data is risk adjusted, so that the provider has the indicator fully under control, because the provider, of course, cannot be held accountable if he or she treats a population with a higher health risk and scores probably scores a little scores lower because he has a more challenging patient.
I think that's clear. That's of course a complicated science and administrative process. But I remember, for example, that English hospitals closed their door at emergency departments because they had a 4-hour deadline to see people after they entered the hospital, and so they wouldn't allow the discharge of ambulance cars. So that is one way, one very obvious way of gaming with it. But of course there are others, splitting up data and stuff like this. How would you avoid this?
Well, because these systems need to be under constant review. Of course, this is also a trial and error process, and if you, of course, the waiting times and the publication of rating times was an important part of the public reporting in England. But of course, providers react, and then the regulation probably has to act again until more reactions are coming that need to be, these systems need to be really under constant review.
Okay, thanks, Mirella. Willem, should we forget about pay for quality, or should we invest in more research and better implementation?
Yeah, I think we should. It's a good question. I think it's always worth to invest more in better implementation and more research. But I'm biased probably as a researcher. But your other question was interesting too, about whether the reason for mixed results because some programs are good and others are bad, and if we would find better results for good programs. In fact, this is what I expected when we did the review, that we would find some programs that are good and others that are bad. But in fact, the reason for different results was not really related to the program, but to the quality of the study, and that's what we found. So we looked at individual programs, and if there was one program, if one program was reported good and there are no mixed results, then that's probably because there are only bad studies about this program. So so we couldn't really find an association between good results for some programs and not so good results for other programs. And I think another thing that it might be important is also that for policymakers, and I think that's also a reason why there will be continuous activities about quality strategies, but also about pay for quality, because I think many of these strategies serve other purposes. So although they are intended to improve the quality of care, they are also intended to assure the public, for example, with accreditation of professionals, that they are taking care of the quality of professionals, and that somehow the regulator is trying to make sure that there are only qualified providers treating patients, because otherwise there might be scandals when suddenly, so if a physician kills a patient and one finds out that he has not been trained, it's a big scandal. If a physician kills a patient but he was well trained, then it's less of a scandal, and because in fact there's not so much that somehow you cannot always make sure that the physician does not kill a patient by accident. And so I think there are important considerations just to make sure that quality is under control somehow. And I think for pay for quality, it's the same. Somehow you cannot really explain why you would pay providers if they do not provide good quality care. So it makes so intuitively sense to take into consideration the quality that they provide, and to think about that bad quality providers should not receive the same money. But maybe you could say a more important punishment is that if bad quality providers are not allowed to provide certain services, then that's an even stronger financial incentive, because also then they won't get the money for treating the patients if they provide bad quality care.
And Will, if a government is planning to introduce pay for quality, should the provider be worried, or should they embrace it?
Ideally, they should embrace it, of course, because if they don't embrace it, and the government should be worried if the providers don't embrace it, because in fact, if the providers don't embrace it, it's unlikely that they will react in the way that the government wants them to react. Because then if they don't embrace it, then if the providers don't embrace it, then probably they will try to game the system and to make money from it without reacting in the intended direction.
Thank you so much, Will. Dimi, you want to come in, and then Reinhard?
But then whether they will embrace it or not also depends on the design of the program, right? So it's
Exactly.
more likely to be embraced if it's a bonus compared to a malus, because then it sort of probably has the determinants of the program also play a role. I just wanted to.
Yeah.
So you mean, like, for example, for a certain vaccine strategy, a provider would get additional funding, and then
Right.
they say, happily, I do the jabs. That would be the way. Reinhard, please.
Well, first of all, I think we should say that that if there are no studies on the effectiveness, that does not mean that the strategy is not effective. I mean, I think that's the first thing in evidence-based medicine. The absence of evidence does not mean there is an absence of effects. And some strategies are, you could say, are so self-explanatory and have been used for such a long time. For example, that professionals are trained, that physicians have to go to university for 6 years, has never been tested in a randomized controlled trial, where you would say, okay, half of the population get untrained people providing physician services, and the other ones get physician services. So on the one hand, I mean, we would all hope that this is the case, and we would not probably get ethical review. But then if you get, say, advanced nurses, and advanced nurses pretend or state they could do the same, we also see that there are no studies, and then the political debate sometimes becomes a bit awkward. That while you say, okay, it's clear that we need to train physicians, unfortunately there are no studies which show that nurse practitioners can do a good job as well as physicians. We cannot introduce it. And so we have to be then honest to ourselves and say, okay, we accept that there are certain gaps in our evidence framework, but then we should, I mean, that should not mean that we freeze the situation. And it's also with a pay for quality and payment systems in general. I mean, we know that some people don't like DRGs. And then they say, oh, there have not been good studies showing that DRGs make sense. And it's the same with P for quality. If you're against it, you say, where are the good studies? But on the other hand, if you pay by budget, if you pay by fee for service, there have also never been studies which show the positive effects of budgets or fee for service. And when we talk about the effects of payment systems on quality, we would say, I mean, if you pay fee for service and pay for, and a complication means that you pay for a second operation, for a reoperation, then the incentive incentives are clear against good quality, but it has been a well-established payment mechanism, fee for service. So we also don't, nobody would do a randomized control trial there, even though we would need it. So on the one hand, I would say policymakers, managers, they should move, but they should also say, people, we need better evidence. It does not mean that we cannot do anything before we have better evidence, but this should go together. And ideally, you see, we would like to have much more comparative studies, which say, okay, if a package of these and these strategies what effects do we see versus other packages of strategies. And so policymakers should make decisions, should move the quality agenda, but better research on the effects should always be embedded in such a package.
That was a question I wanted to have for the final round, the benchmarking and the comparison, to whom do we compare ourselves? I saw this wonderful website of the British hospital comparing to the average of the British hospitals, but I have doubts about British hospitals. Why don't they compare to German hospitals, for example? Maybe the German hospitals have a far higher standards. Why are they so why do they stop short for the Swiss hospitals, which are probably the best in the world? So how do we compare? I mean, we all agree comparison is really key, and you provided good in your presentations. You provided very good reasons for comparison. But when we do it systematically, in terms of quality improvement, to whom do we compare ourselves? Is it to the neighbor, with all risk adjustment, of course, or is it to other countries, the best in the league, or do we rather construct something, from the literature, what would be an achievable or desirable target? Please, the round. Mirella, very quickly, Wilm and Reinhard. And Dimi, of course. Dimi, go first.
No, it's okay.
Oh,
go ahead. Mirella, go ahead, please.
Mirella.
Thanks also for the question. So yes, of course, we need comparisons, and benchmarks are important in order to see where we need to catch up with. But of course, even the comparison don't show what is the best practice or what is really the amount of care or the quality of care that we really need, because this cannot come from a comparison. This must come from a different quality strategy, maybe from the guideline strategy. So, of course, public reporting it can only report what we can achieve by a comparison.
Thanks a lot, Mirella. Wilm?
I'm sorry, my internet connection got lost for a second, but I'm now back. So I didn't really hear the answer, but I would say that so in pay for quality strategies, in fact, there are different strategies that are used to set the benchmark from where you would receive a bonus or not. And so this can be either related to the average, it can be related to the top 20 performers, it can be related to an absolute threshold that is based on evidence in the literature. So I think all these different options that you just mentioned about how to set the benchmark, what to compare with, exists in different studies or different programs. And ideally, in fact, pay for quality programs use a mix of these approaches, so that they, on the one hand, give the opportunity for providers to receive a bonus if they improve, but they might still be below average. Or on the other hand, if they remain amongst the top 20 and then they get the bonus for achievement, and also to have a bonus with regard to pre-specified thresholds.
Dimi, very quickly, and then Reinhard, final words.
And can you then also compare to yourself, like your performance in the previous years, to see if you are actually improving based on your own internal benchmark? Probably a combination, I would say.
Exactly. So if you're improving against yourself, that would be you get
possible. You are already top notch. You have a ceiling effect there, Reinhard.
Well, I think, I mean, it becomes clear that we need to have a broader picture. I mean, if hospitals in the UK only compare themselves against each other. Even if they would compare themselves against last year, they would not find out whether certain things are done maybe in Switzerland or in Austria in general much better, and they would have as a group room for improvement. Which means that I think ideally within Europe we would say we need a European-wide comparison where we can learn from. And most importantly, that means that when it comes to indicators, how we can measure quality, that we need to work together. If every country or every group within a country develops its own quality indicators, how to measure success, we cannot find out what we can learn maybe from corners of Europe which we have not accepted. So it's important that within Europe we develop indicators and standards to be able to compare ourselves. We don't have to have to standardize the policies directly, but be able to compare ourselves across Europe.
And I think this book makes an extremely important contribution to this aim, and you can all download it free from the Observatory website, and it's really very accessible and readable. And thank you so much. Thank you so much to all the panelists, to the speakers. Thank you so much to the participants. I was reassured by one of your participants that there are no questions, but that everybody was listening very attentively. So we hope you enjoyed it, and bye-bye. Have a great day.